there is a repetitive cessation of breathing during sleep. So what happens is there is recurrent episodes of apnea leading to repeated hypoxia and hypercapnia, and subsequently there is damage to the retinal nerve fiber layer. So the aim was to study the RNFL thickness using OCT in patients with different severities of OSA, and we hypothesized that RNFL thickness will vary with the severity of OSA as measured by the apnea-hypopnea index. This was a hospital-based prospective cross-sectional study which was conducted at All India Institute of Medical Sciences, Rishikesh. And we included the patients who were diagnosed with OSA by level 1 polysomnography, aged more than 18 years and willing to provide a written informed consent. Those with psychotic or neurological disorders, any substance abuse, or any other chronic diseases or media opacities were excluded from the study. Now, video synchronized polysomnography was conducted as per the American Academy guidelines, and based on the AHI, the patients of OSA were classified into mild, moderate, and severe groups. A comprehensive ophthalmological evaluation was performed in all the patients, and analysis was done by the SPSS version 28 software. So 90 eyes of 90 patients were included, and the average age was close to 50 years. About 1/4 of the study participants were the female gender. As far as the severity goes, 39% were mild OSA, 30% moderate, and 31% were severe OSA. If you look at the average RNFL thickness, it was 86.76 microns. And as you go from the mild to moderate category, it decreased from 89 microns to 81.36 microns in the severe category. Similarly, if you look at the intraocular pressures, they were about 16 in the mild OSA group and increased to 17.43 in the severe OSA group. So we also did a quadrantic analysis, and we found that the average as well as the superior quadrant RNFL thickness was significantly different between the OSA severity subgroups, and this was inversely associated with the apnea-hypopnea index. There was a weak but significant negative correlation between the AHI and the average RNFL thickness. The intraocular pressure differences among the three OSA groups were statistically significant. However, there was no statistically significant difference between the CCT, GC-IPL thickness, and CMT among the three subgroups. So the severe OSA patients had significantly lower average RNFL thickness as compared to the mild OSA patients. This is consistent with previous studies which have been performed elsewhere as well. So superior quadrant RNFL thickness was significantly lower in the severe OSA subgroup, which is in concurrence with studies which have been done by Lin and Lee et al., who also found the superotemporal thinning. And this could be possibly because when OSA causes ischemia and anoxia, it may first affect the superior and the inferior quadrants because of a relatively denser RNFL distribution in these quadrants. Also, the intraocular pressure was significantly higher in patients in the more severe OSA group, which is consistent with findings by Guven as well as Zin et al. And decrease in the ocular perfusion pressure possibly led to results in an elevated IOP and subsequent damage to the RNFL. The limitations of the study were a small sample size, lack of a control group, and we did not do OCT angiography. So in conclusion, the average and superior quadrant RNFL thickness was significantly lower in patients in the more severe OSA group. Patients with severe OSA had higher IOP as compared to the mild OSA group. So moderate to severe OSA patients should be screened for glaucoma. And for known glaucoma patients, screening for OSA may help in monitoring the progression of glaucoma and may prevent blindness in these patients. Thank you for a patient hearing.
Severe OSA. So what was the diagnosis? Was it more common in normal tension glaucoma or POAG.
Ma'am, these were all patients who were normal patients who were diagnosed with OSA. These are not glaucoma patients at all.
So IOP, what was the range? You said higher IOP,
yeah.
so what was the range?
The range of the IOP in the severe OSA group was in the range of 16 to 19.
Okay.
As compared to the mild group who had lesser this thing. So what they say is that possibly because whenever there is episodes of apnea and hypopnea, there is reperfusion that leads to subsequent inflammation. Then there is also increase in the cerebral pressure, so that the cerebral perfusion pressure
those
decreases.
Patients had some symptoms. Why did you advise and chose those patients?
Ma'am, those were diagnosed as the obstructive sleep apnea patients.
You chose the patients who were already...
Who were level 1 diagnosed obstructive.
So that means the patients were referred to you from the physician's clinic. So what was the criteria in your clinic?
Basically, we collaborated with the Division of Sleep Medicine in our institute, and we planned the study accordingly. So those patients who were first diagnosed with obstructive sleep apnea by polysomnography, they were then sent to us for further evaluation.
So the patients who are prone for this OSA, sir, they are having many more risk factors like weight, BMI. So did you include those things in your study?
No, we did not include the weight and BMI, but we did include the diabetics and hypertensive patients. And we did a subgroup analysis of those patients. There were 8 patients who were diabetic, 12 were hypertensive, and 8 were again both diabetic and hypertensive. We did a subgroup analysis and found there was no significant difference between the other population and the diabetic and hypertensive group.
Okay, so that was there.
Yeah.
And any confounding factors did you find when you said that the final analysis was done for RNFL?
I don't think so, not really.
Thank you.